Welcome. Good morning to those of you on the West Coast, and good afternoon to those on the East, like me. This is our fourth professional development webinar of this academic year, and we're happy to have you join us to address mentoring of research activity in medical education and training. I am the Associate Director of Rural Prep, and Davis Patterson, the Project Director. We will be facilitating this webinar with our guest, Dr. Bill Phillips. Next slide, please. I will introduce you briefly to our agenda for the day, after which we'll ask Dr. Phillips to present. Dr. Patterson will then initiate a conversation with Dr. Phillips, and I will then be asking all of you to join into that. The way we will do that is through the chat box, as you just heard. Please copy your or write your chat comments in there at any time, and we'll be monitoring that. Next slide, please. So Rural Prep is the collaborative for rural primary care research, education, and practice. It's a collaborative among three schools of medicine: the University of North Dakota, the University of Washington, and Ohio University. And it's funded by the Health Resources and Services Administration, Bureau of Health Workforce, Division of Medicine and Dentistry. Next slide. Our mission is to improve and sustain rural health through community engagement and research in rural primary care health professions education. We do that in various ways, one of which is to do professional development webinars like this. This is my opportunity to just make a comment about our micro research, which is another strategy we use. And today's webinar was really prompted by our desire to help those micro researchers who are already on our part of our program, and those who may be applying now or anticipate applying in the future, to help them acquire a mentor for their project, and to help the mentors do the best job they can in guiding the micro researchers through their project. Next slide. So these professional development webinars in particular happen 4 times a year. We will be having our next webinar on July 26th, but generally these occur on the 4th Thursday of the month in the months you see above. Next slide. Here are our objectives for today, and I'll let Dr. Phillips maybe say a bit more about the first 3. The last objective is the objective of every webinar that we have, and that is, we hope as a result of this webinar, you will be encouraged to join the Rural Prep community of practice in rural primary care health professions, education, and training. Next slide. So I'm going to ask Dr. Patterson, who is Dr. Phillips' colleague, to introduce him while Dr. Phillips shares his screen with us. Dr.
Thank
Patterson.
you. Thank you, Randy. So Dr. Bill Phillips is a clinical professor emeritus in our department, the Department of Family Medicine at the University of Washington. And he's worked with medical education and primary care research here since 1979. He is a native of Seattle, where we're located, and graduated from the UW School of Medicine and earned an MPH at the UW School of Public Health. He has practiced full spectrum family medicine in Seattle for 20 years. He is a founder and currently senior associate editor of the Annals of Family Medicine. And he's also served on scientific and professional leadership roles at the national and international levels, including as a member of the U.S. Preventive Services Task Force, has been president of the North American Primary Care Research Group, or NAPCRG, chair of the American Academy of Family Physicians, Commission on Science, and a variety of other roles. And he's a fellow of the American Academy of Family Physicians and the American College of Preventive Medicine. And so I'm going to let Bill take it away.
Hello. Thanks for joining us for the program today. I'm hoping to share some experience and some thoughts I've had in working both as a mentee and as a mentor of a variety of new researchers, early career researchers, and scholars at all points in their career that realize they have more to learn and seek out experience and mentorship. Here are webinar goals. I think we'll move beyond these, but to begin with, we want to identify more successful and less successful models of mentoring, both from some reading and experience I have, but also from your personal experience. So I'm hoping that you, as we go along, can think back upon the times that you've been a mentor or a mentee in the scholarship and research realm, and what's gone well. If that leads to questions, we'll be eager to talk about those at the end of the session, and I'm really looking forward to hearing your thoughts about your experience. We're going to describe the different roles, at least 3 complementary roles for mentors, and then talk about a couple of tools that can help mentors work with mentees and mentees pursue their career and their research goals. And one of those is the professional development plan. Here's the boilerplate, nothing to disclose, so we're not going to talk about anything dicey. So we don't have to worry about all these CME sort of constraints that we pay so much attention to in that realm. So we're going to talk mostly today about the mentorship role, but I want to recognize that there are other important roles, and although they may overlap and be complementary to, they're a little bit different than actual mentoring. So there's the advisor, the coach, and the mentor. The advisor is usually task-oriented, it's pretty directive, often it's an answer to a specific question, and it's about an episode. Think of answering a specific question from the new researcher about how to format a research article, for instance. That's an advisor role. A coaching role is a bit more involved. It usually involves developing a new skill. It's more of a shared process. Sometimes there's strategy, when to use this skill versus the skill we learned last week. And it's usually about some current learning, some current task, more like what we see as an attending on the wards. The mentor role aims more not at just tasks and skills, but at professional and personal development. The relationship's more of a partnership. It's ongoing. We share experiences, and we're aimed at the future performance, career, and success of the mentee. Which role are you going to be playing at any given time? How do you know which slot to be filling? Well, the best advice is to ask what the learner wants. Share the expectations, be clear about that. And if you change from an advisor to a coach to a mentor role, sometimes it helps to be explicit about which role you're going to be taking up. Now, there are other roles besides mentorship that we want to talk about. There's a manager. We're all managers of patients. We're often managers of our clinical settings. That's a different thing as detailed here. Role modeling can be different too. Now, all good mentors probably ought to be role models, but not all role models are mentors. Think perhaps of your ward attending when you're a medical student. They were certainly a role model, but they might not have been a mentor to you. The mentor might have been your R2 or R3. And a sponsor. Again, most good mentorship relationships involve sponsorship, where you're promoting the learner, you're their champion, you're helping them find and succeed at their own career goals. But one can be a sponsor without being an in-depth mentor. So there's a couple of other complementary roles. Everyone deserves a mentor. If you have a mentor, if you know an experienced professional investigator, ask that person who their mentor is. They'll have more than one name. And I think everyone deserves to be a mentor, and it's an exciting process. Almost all physicians and healthcare professionals and other clinicians seek to be teachers in some role, and mentoring is a special form of teaching. Now, here's a chance to reflect back. Think about times when you have been a mentee and when you have been a mentor. All of us have been both. You're a mentor perhaps to a medical student or a pre-med, or an intern or R1 on the service with you. Or maybe it's outside of medicine. Maybe it's at the Boys Club or Boy Scouts or some other sort of circumstance like that. So think back to your own experience as a mentee and your experience as a mentor. Then think about when that worked really well. It was a good relationship, or when it went bad. So we have 4 cells in this table, and I just ask you to maybe even make a few notes now. Explain for each of those cells, when you had the good experience, what made it go so well? What did you give to the relationship, and what did you get from the relationship? Think about when it went not so well, or perhaps was a disaster. What went wrong? What could have been better? We have research data and experience to describe what makes great mentors and mentees. Some of this comes from opinion surveys, but some of it comes from actual outcome studies. So I'll share the highlights with you with these bullets. What makes great mentors? They're available and accessible. They recognize potential in the learner. They provide opportunities to the mentee. They inspire the learners to take new risks. Now, this is by report of the mentees. So the mentees think the best mentors inspire them to move beyond themselves and to grow into new areas. And they help the learners build identity, competence, and effectiveness. What makes great mentees? Great mentees know themselves, their strengths, their weaknesses, and their needs. They show appreciation, seek and accept feedback in a positive way. They're organized and they take the initiative. They actively manage the relationship. The mentor's there to help, and a good mentor is available, but organizing the meetings, the tasks, the work products, and so on is a duty that's best taken up by the mentees in service to the relationship and in help to the mentors. They're respectful and considerate, and they're open to new ideas. So here's one summary that maybe is abstract, but I think helps us understand the depth of the relationship. Mentoring is a reciprocal relationship of learning and teaching among colleagues. And despite a difference in experience, in knowledge, and perhaps in hierarchical seniority, when they work best, I believe a mentoring relationship from both points of view feels like colleagueship. Now, we have some evidence on the effects of mentorship on both parties. When new researchers and people involved in scholarship have a good mentorship relationship, they enjoy improved career advancement. That's usually in the academic environment, so they have increased productivity, and that's usually measured in publications, grants, and leadership opportunities. People with mentors get more of that action than people without mentors. What do the mentors get? They get improved career satisfaction. They get to share their workload, and as a result, they actually get more done. They're able to broaden their research palette and increase their impact in the field. So mentoring's a two-way relationship. This is an image that I love. It's a soul shaker. This is actually the logo of the UW School of Public Health, has been for 30 years. It's a soul shaker. It's the only co-salish art form that's symmetrical end to end. And it's a shaker that is used by shamans to drive out evil spirits, or by families to hang at the top of their longhouse to keep evil spirits out and health in. It's symmetrical. So the best mentor-mentee relationships, perhaps like the best relationships in life, are explicit, transparent, and shared. And those values, explicit, transparent, and shared, can extend to all the kind of work that mentors and mentees do together. Here's a few of the tiles on the palette, but you can fill out others. Shared expectations, work style, authorship, work products, timeline, learning style, teamwork. On each of these topics and many others, if the two people working together can be clear, can agree, and keep each other up to date, the relationship and the work will go best. Now, we've talked about mentors as if there's one senior mentor and one junior mentee, but of course there are multiple relationships. Most mentors will be mentoring multiple learners or colleagues at the same time. And likewise, most mentees, most new or learning or early career researchers should have more than one mentor. Here's a couple of examples of pretty common types of mentorship that you might have at the same time. You might have that veteran investigator, that professional scientist, especially if you're a practice-based clinician or a member of a rural health team where your primary job is not getting grants and writing papers, but you're now involved in scholarship and research. You will do well to have a mentor who is a veteran at the rules of that game. At the same time, you probably want a mentor that's a topical expert that really knows the ins and outs, the literature, the measures, the technology of running research about the topic that you're studying. If you're in primary care, an academic family physician, somebody who has been through the mill of balancing patient care, administration, scholarship, family, community roles, that can really help. And sometimes there's a community elder. That might be if you're working with a community, such as in a community health center, but it might also be some other community that you come along the way. I have fellows that work with communities of refugees, for instance, and it's very important to have a community elder as your mentor to help guide you, just as these other people guide you through academia, research, journals, and technology. Now, one of the best values of having a mentor is to help you make critical choices, especially early in your research experience. Those are choices about what team to join, what research question to pick up, what study method to use, what journal to pick, and how to organize one's career. So, as you recall from the Cheshire Cat with Alice in Wonderland, if you don't know where you're going, it doesn't really matter which road you take. So I want to talk a little bit now about how, from both points of view, for the mentee and the mentor, one can empower these choices and inform the route that one takes through these many choices one has early in a research project or in a research career. Now I'm going to refer to these three tools. When we talk about research, if you've done a research course before, it's almost all about the research proposal. It's about what study technique to use and how to state the question and what stats you're going to use. We're not going to talk about today. That's a different course, a different time. That's the research proposal. I want to talk instead about these more foundational pieces, the professional development plan and the professional mission statement. We'll start there because that's the most foundational. So I believe everyone should have a professional mission statement. These are general descriptions of your lifelong career goals. These are high and lofty statements. They should outline what professional development you seek, what knowledge, skills, and expertise you want to internalize and make part of your professional work. It should have milestones and timelines. Now, I, for 15 years, ran a research fellowship training program in primary care at the UW. So I have a lot of experience with working with these people who were residency trained clinicians in family medicine, general internal medicine, general pediatrics, who are now getting research training and wanting to move into a career as an academic researcher. So with them, I would ask this 5-year, 15-year sort of interval. With different groups, it might be different intervals. The 5 years is, where do you want to be in 5 years? Imagine now you're residency trained, you've got some experience in the faculty, you're at the point of being promoted to associate professor, or maybe you've already done that. You're a successful early career scholar. What will you be doing? What will you know? You'll be the go-to guy with what kind of skills and knowledge? I think those questions help people create this mission statement, know who they are, know who they're after. At the same time, I like to ask that 15-year question. Okay, now you're well established. You're an expert on something. You've published several papers. You've been a member of many teams, perhaps the leader of some. What's your contribution been? What does your life work look like? Who will you be and what will you be doing? I'm surprised at how many people have spent so many years in training and not pondered those questions as deeply as I think can be valuable to them. So I like those kind of intervals for the timeline and milestones. There should be some specific goals and objectives, and you've heard of this SMART acronym for specific, measurable, attainable, relevant, and timely goals. You can look it up on the internet. Some of this information can be found on the net relating to graduate students, less to clinical trainees. A lot of it comes from the business world. So you have to kind of filter it as what's useful for those of us who spend time in scholarship, care, administration, and teaching. Now, in using the professional mission statement, it's there to help you make critical decisions. When Alice reaches that fork in the road, how does she know which one to take? Well, if her choice can be informed by knowing where she wants to go in the next year, the next 5 years, the next 15 years. Once you have this document, you should review it regularly, change it often. It's a living document. It's not meant to constrain you, but to inform you. Thinking about it and reflecting on the questions can actually help you create direction and momentum. Let your personality shine through. Consider more than one statement. People who take this seriously will often have a personal mission statement that talks more about family and community and spirituality. If you're inclined to use this technique in those areas of your life, I think that too can be powerful. And those statements intertwined with your professional mission statement probably make for the best strategy and the best path forward. Share your statement with people important to you, certainly with your mentor, also with your spouse and family. If there's a piece of your professional mission statement that you feel a little embarrassed talking about, it probably deserves more thought. You either need to change the mission or develop more confidence and a better sense of why that's your chosen path. You should review this statement with your mentor very early in the relationship. This is a tool that helps your mentor know who you are and where you're going, and it allows the mentor to know what they can bring to the relationship to empower you to reach those goals. Now, this is just an example. I won't read it to you. This is from one of the fellows, and you can see when you take a look how it moves from very general, improving management of chronic illness in primary care, to very specific. I want to be an expert on the assessment of language and cultural proficiency among patients and clinicians for elderly immigrant Asians. That's in fact what this academic family physician chose to do. She acquired these skills, she wrote several papers, and this is the basis for her career. I can also share with you that she's on to doing other work related to other populations, but this was her guiding principle for her formative time learning to be a researcher. Now move on from the mission statement to the development plan. This is the lineup of intermediate steps that will allow you to reach your ultimate goal. I don't need to read through the entire list here. This can be used as an outline, and every element of this outline can be expanded, but it includes your clinical, your academic, your administrative, and your scholarly work. For the research, publication, and presentation elements, I've started them because we'll talk in just a second about how you can blow up and expand that part of the outline. You should have information about the grants that you are trying to achieve, the organizations and meetings you'll attend to, and here's a place to put in the mentors, and you can make a crosswalk map between the projects and activities and the specific mentors. Different mentors will show up for different activities that are part of your professional development plan. For each study, outline them like this. What are the specific objectives, work plan? Who's in the team? What are the responsibilities? Who's the mentor? What's the role of the mentor for this particular research study? For the publications and presentations, these are some subunits to put under that aspect of the that element of the plan and the outline. What's the target journal? Who are the co-authors? What's the order of authorship? Those things should be worked out early in the process. They may change as you go on, but they're essential early elements in outlining how publications and presentations are going to contribute to your professional development. I suspect you've seen some Venn diagram that looks something like this. It looks at the different domains of our lives and asks how we can organize our activities, our professional and perhaps personal activities, to overlap in such a way that they increase the likelihood that we'll meet our professional and our personal goals. The closer you get to the overlaps between the different spheres, the closer you are to the sweet spot where most of your work will bring you most of the joy and most of the results. Now, how do you find a mentor? How do you find several mentors? Especially if, like Lewis and Clark here, you're out on the frontier. Well, there are strategies for finding a mentor. Remember, it's a relationship. It's a two-sided relationship. And like any relationship, the usual early steps are finding someone who shares your interests. Those can be topical interests, or in the case of research, methods interests, or interests in patients and populations in clinical situations. That's where most of us live. That's where our passions are. That's why we got involved in healthcare. And if you can find someone who shares those interests, that's the person you want to contact. Maybe that person can be your mentor, or maybe she knows somebody that she can refer you to that also shares the interest. Research is a human activity. These relationships are human relationships. Here's some potential mentors, places you might look. Faculty members, of course, are experienced and have some degree of professional commitment, if not pay and time to be mentors. They're people to talk to. And you might meet these people as presenters at a scientific meeting or at a CME meeting, or even a community meeting where they're talking about health-related issues. Authors, when a scholar writes a paper, they are thirsty to reach readers. The actual feedback they get is very abstract, very delayed, and often very little. So if you email or phone up and talk to somebody who wrote a paper that you're interested in, they're usually delighted to hear from you. Don't be shy. And by looking at authors and presenters, you can zero right in on people who have the interest you share and the expertise you need. Also, recognize what you bring to the equation. You bring, for the clinicians among you, a very special brew of clinical expertise, your training as an expert clinician, a primary care perspective, and a practice experience in the community. In many of your cases, that's a rural community. Think of how valuable that is to a scholar, a researcher, maybe a PhD expert sitting in ivory halls somewhere. Now, again, with my research fellowship, these people were new to the university environment. They'd come right out of residency or maybe out of a few years in community-based practice. And they wanted to learn, for instance, with the woman that wrote that mission statement, they want to learn state-of-the-art techniques for assessing cultural linguistic adaptation after immigration. That's pretty rarefied. Well, it turns out that at the University of Washington, there is an expert on that. They've, for 20 years, run a national study measuring exactly that. That scholar happens to be over in the School of Social Work. So that seems pretty distant, but you pick up the phone or write an email and you get a hold of that person and she says, really? You're a physician? You're a primary care physician? You've actually worked in the community? I'm always looking to find that. I've perhaps never had the benefit of a colleague with those skills. So often you can bring gold to the senior investigator, to the team, to the mentor. Also helps to be clear about what your ask is. What is it you need from this particular mentor at this time to move forward on these goals? And that's helped by these tools we've already built, the mission statement, the development plan, and this idea of multiple mentors. You don't need everything from every mentor all the time. And if you can be clear and transparent and share your needs and what you're asking about, it can make your ask a much easier thing for the mentor to say yes to. Now, these mentors can be helpful in many things. I want to focus on the task of finding and focusing a research question, mostly because I think it's a very exciting topic and because this is an area where a lot of early career researchers stumble. Especially if they're in primary care. Primary care people are interested in so many kinds of people with so many kinds of problems, such an available palette of treatments and interventions that there's a lot of things to be interested in, and it's sometimes hard to find and focus a research question in the kind of way that you can move forward on a real project. So I want to focus on that, and I believe this is one of the places, this is one of the tasks that the mentee can get the most help from a mentor and where the mentor can have the greatest impact upon the new researcher. Now, sometimes the idea of choice of question is an illusion. Sometimes you're signed up with a team or a group or a practice-based research network where if you're going to participate, you're going to do the work that they have already outlined. And that's okay. That can be a great learning experience that maybe is the best for many of us at some point in our career, especially an early point. So choice can be sort of an illusion, but I want to talk about the exciting option of at least knowing where your interests lie so you can shape the questions as you work through them with your mentor. So often you join a primary investigator or a team, as I said, a practice-based research network, or maybe there's a grant that defines a set of questions, usually 3 or 4 specific aims. So you're offered this kind of set of choices. And you don't get to pick just the black car, but you got to pick between a couple of different research agendas. That's okay. If you have your mission and your development plan in place, you can decide which one of these is going to be a best fit for you. The researcher's goal is to define a question that's researchable, a study that's doable, results that are publishable or shareable, and eventually to develop a sustained program of inquiry. And at each step, this is about defining and refining the questions. Now, questions can come from a lot of places. They can come from your work and work environment, the patients and clinical problems you see, or the literature you read. One of the great things about being involved in the actual care of patients in the community where they live is you can see the richness and subtlety of the problems of primary care, and it's at those points of subtlety where the greatest questions arise. If you have a general idea in mind and you want to get a quick update on what's known and what's not known and what research is further needed, look at review articles, Cochrane reviews, guidelines and consensus statements, and trial registries. Those are formalized in such a way that they almost always have a section on what research is further needed. If you want to know about what's needed next to increase the uptake of mammography for the prevention of breast cancer, go look at the U.S. Preventive Services Task Force statement, and you will find a whole section on research gaps and suggested approaches to those new questions. So that can be a leg up on helping you find new questions. There's a life to every question as it goes through the cycle of research. I have some sessions I provide on those. I like to look at it this way, that we need to find the question, refine the question, define every element of it, design the study, and then align the whole thing to the mission that you and your mentor and your community and your team shares. So as you can imagine, each of those has its own technology. We won't go through each of those, but just be aware again that choices have to be made at each of those steps, and those choices can be informed by understanding your mission, and your mission can be understood by working through those tools and having your mentor help you develop that. Now, I published this paper. It was in one of the supplemental readings for this session just recently in the family medicine literature, kind of summarizing the research, the mentoring experience I've had with these new researchers in our family medicine internal medicine and pediatric primary care fellowship program. And the real question I'm asking as I did this review was, what passion motivates your curiosity? Not just, is it mammograms or breast cancer or patient adherence? Why do you ask that question? And I believe the closer we can get, and as mentors, one of the important tasks I can do is to drive the new researcher to ask that question. What really motivates your curiosity? Why do you ask that question? In doing that now for 15 years with 100 people, I find that at least for these people I'm working with, primary care physician researchers, that key question, that driving passion usually boils down to one of these three P's. It's either about patients and population, people, about problems, or about the process. So here's some examples. Problems might be cancer prevention, family planning, otitis, pap smears. Those are clinical problems, and a lot of our research is focused through the lens of problems. But other people are interested in patients and populations, refugees, immigrants, as in the case of that woman's mission statement that I showed you. I've had people devote their careers to jail health or improving the care of demented patients, and you can imagine a longer list. Many people are interested in processes, doctor-patient communication, clinical decision-making, etc. And I'm sure each of you have interests that could fall into each of these categories. Furthermore, I think any research question you ask can likely be seen through the lens of either problems, patients, or processes. And I hope that this model can help you decide which is your driving passion. And if you're a mentor, you can use this model to help new researchers explore their passions. Let me give you an example. Let's just say we have a team around the table and everybody's there because they agree they want to do research on the antibiotic treatment of otitis media in children. That's actually a very common primary care research question. There's still lots of questions to be answered. It's a timely and relevant example. But now I'm going to take it from the point of view of three different researchers, each of which uses one of the different lenses. So the person that says, I'm interested in patients, might volunteer this viewpoint. I'm here at the table about otitis media because I want to improve the care of little kids with a common illness and reduce their suffering. Otitis media is a common problem among that group. That's why I chose otitis media. They're not really an ear guy or an infection guy. They're about kids and the health and welfare of children. They're driven by passion about patients. Another person takes the problem lens and says, I want to reduce the unnecessary use of antibiotics in the community. Otitis media is a common reason for unnecessary antibiotic use in primary care, and that's why I'm at this table. I'm not interested in children's health as much as the person who just spoke. I'm not so interested in otitis media or ears. I'm really interested in antibiotic use, and otitis media is where the action is. The third person who uses the process lens might share this. I'm interested in shared decision-making between doctor and patient, in this case, parents. The choice of antibiotic treatment is just a good example of that. I could be doing it not in little kids. I could be doing it not with otitis media. I could be doing it actually without antibiotics, but this is a perfect model for me to study this process. Three different lenses dealing with the same clinical entity, the same clinical question, and possibly the same research question. But if each of these persons pursued their own passion, they would come out with a slightly different take on the process, and each study would be complementary to the team's efforts. Now, once you get a handle on your passion, your lens, your question, and you have a focused question, you want to ask, does it really meet your personal goals? Again, this goes back to our foundational documents. What is it you want to learn? Do you want to learn statistical analysis? Do you want to learn to run focus groups? Do you want to learn how to write papers? There's a lot of things we learn in the process of scholarship and investigation, and you should have some clear ideas what you want to learn and what this project will bring you as an opportunity to learn. What do you want to do? Do you want to sit behind a computer all day? Do you want to be out in the community doing interviews? Do you want to get experience with a team? Who do you want to work with? This might be mentors, it might be experts, it might be community groups. What outcome do you want? Is it looking for a publication or early data, pilot data for a grant? The clearer we are about the outcomes and share that with the people on the team, the more likely we are to get there, according to the Cheshire Cat. How will my involvement in this study advance my professional development plan? And how does it serve my professional mission? Does it help me get to that 5-year milestone or that 15-year goal? Now, of course, we need to align the question with the team goals as well. Research is a human activity. We almost always do it with others. Like primary care, research is a team sport. So let's go back to these questions again. The team had, or the grant, or the PI, or the laboratory in which we work has 4 defined questions. You could pick any of those to work with. But notice that there's other questions kind of interspersed there in the test tube rack that are just next to, or actually in between these other questions. And I believe for early researchers that are working with a team or a senior investigator, your goal is to find a spot right among those, right next to those, so you can take a piece of the larger project and make it your own. And the closer that project of your own is to fulfilling your passions and your plans, the more likely it'll be a positive experience, which means it'll more likely it'll actually get done, it'll get published, and it'll lead to the next step. Now, we have at least 3 built-in ways to ask new questions about an existing project or study. So imagine again, we've got this team that has 4 defined research questions. We're looking for the interstitial complementary questions. Almost always you can take an existing body of knowledge or a defined research project and ask, well, how would this work in primary care? That was the original problem with all the research on otitis media. There was a lot of research, but it all came from ENT referral clinics, often from academic medical centers, and was irrelevant to what you and I and our teams do with the care of otitis media in real kids, in real clinics, in real communities. A tremendous opportunity for research. You can also apply it to a new patient population. That social worker expert that did the language acculturation work had 20 years of experience doing it with Latinos and Spanish-speaking immigrants. The work had never been done on Asians, and particularly not on elderly Asians. So our fellow had a prime opportunity to take the same technology, the same tools, and apply them to a new population to ask new questions and to get valuable new information. Or apply them in a new setting, outpatient setting, community setting, rural setting, community healthcare setting. Those are where most of the people get most of the care most of the time, but it's an embarrassing shortcoming of our research system that so little work has been done there. That work is sitting, waiting for you to do. So the goal then is to find the sweet spot between what you're interested in, what your mentor's interested in, and what's available in the study resources. What does the data let you do? What does the budget let you do? What if you're going to do focus groups with these community members, what couple of questions could you add on that would be useful? If you can find that sweet spot, you'll build research momentum. You're going to ask good questions that lead to more good questions and do studies, good studies that lead to more good studies. Because your eventual goal is to get the sustained program of inquiry, and you will have around you a skilled team, a network of colleagues that include both mentors and mentees, and a relationship with funders. Now you're a researcher, now you're a mentee, now you're a mentor, and you have momentum for a sustained program of research. I hope this can help both the mentees, the mentors, and the teams in which you work be more productive and find more joy in your work. Thank you. Do we have time for questions? And do we have some questions lined up?
So at this point, Dan, Davis, you want to start us in the discussion, and then I will join in as able. We have about 8 minutes or so to do that.
You bet. And I really want to encourage folks out there to feel free to share any of the good, the bad, and the ugly of your mentor or mentee experiences, as Bill asked. We do have one question in the chat about getting access to presentation. Okay, and Randy's answering that. So we will have the webinar recording available, and I will have to check with Bill about sharing the slides. But I wondered, Bill, if you could talk just about, briefly about one or two of your research mentors and share with us. Let me share my video too, so you can see who I am talking here to you. So I wondered if you could share one of your research mentors that had an impact on you, and a concrete example of that.
Well, let me think back. Perhaps my very first research mentor, I was a medical student. I picked up MPH studies, learned research methods in health services and epidemiology. But my research mentor was the chairman of the Department of Biostatistics. Why biostatistics? And the reason is because he shared a passion in the topic that I was working on. At that time, the topic was the epidemiology of euthanasia. Despite his academic stature and his very busy schedule, we had regular brief meetings that had specific work products and agendas. I was supposed to bring something to the meeting. He was supposed to bring something to the meeting. Every time I met with him, I felt his enthusiasm for the work I was doing and the contribution I was making. Also, I remember a lesson he left with me, and I try to share it with others. He was a data analysis guy, right? He was a biostatistician, and he always wanted to make sure we didn't shortchange the effort time spent on analysis, but he thought that was, though important, even less important than the planning stage of research. So a message he left with me was, think about, in planning a project, think about how much time it'll actually take you to do the study and collect the data. Then double that period of time, and that's how much time you should expect to spend doing your data analysis. Then double that time, and that's how much time you should spend in planning the study so that everything goes smoothly. He had an impact because of his enthusiasm in this topic, his confidence and enthusiasm in me, and together we were able to work together in a very orderly fashion, and I took a lot of weight from that. It was a good learning experience for me, and that's what inspired me to be a researcher, and then to bring the family medicine primary care point of view to the research enterprise.
Great, thank you. Randy, were you going to ask the next question? I was just
going to say, we have several questions popping up, and so I want to give time to them. One in particular was, what if you're co-mentoring and your co-mentor has a different concept of mentoring?
So now we're talking about a three-way relationship, at least, I guess, with a new researcher and two mentors. Remember that mentoring relationships, as described by experienced mentors, usually go best when the mentee is managing the process. They even talk about managing up and organizing. So I think being transparent and explicit is important, and there may be a role for the mentee to actually say, okay, it's a triangle here. I'm working with two mentors. Let's be clear about what I'm going to do with each of you. And that could inspire a conversation between the mentors where they say, I'll do this part, you'll do that part. And if there's big style differences, perhaps they can end up with different task agendas so that different people are doing what they're most interested in and what they're best at. The question of what they're actually delivering should be driven by what's best for the mentee.
Yeah, and I want to emphasize what you had said earlier, that mentorship is mutual. And the mentee brings a lot to the relationship, and they need to believe that. A lot of our micro researchers are students, and they might diminish their contribution to the relationship, and they need to think about it as a very valuable part of the relationship.
They need to work at being colleagues. My fellows would, as instructed here, would always have several mentors, and I can share that one of the things I spent a lot of mentorship time on was helping the fellows manage other relationships with other mentors. And so you kind of share around and get advice. As an active professional learner, it's kind of up to the mentee to come up with a plan of what is it that Dr. Jones offers? What's the best thing I can learn from her? It may not be the same thing I learned from Dr. Sullivan. And you need to manage your own learning and to some degree manage your own mentorship.
One comment I wanted to make to Bill. So I'm actually not a clinician. This is Davis. I'm not sure why my video isn't showing, but anyway, this is Davis, and I have a PhD in sociology, so I'm not a clinician, and I really appreciated your comments encouraging students and clinicians to link with people like me. I think that's really been one of the secrets of my success as a healthcare researcher. And the other thing I'll add too is that, you know, I live in urban Seattle, but my focus is mostly rural, and I certainly have some rural experience, but people in rural places also kind of help ground me and keep it real. So I learn a lot from people that seek me out.
We have another question that I really identify with, and I'm going to take the second part of it. What's the best way to overcome the fact that I'm a clinician, first-time researcher, now I'm pursuing academic interests, and I'm experiencing some hurdles. What's the best way to sort of get started?
Well, the best way to get started is to share an interest with somebody who's got more experience at the research game than you do. Sign on with an investigator, with a team, with a network, with a practice-based research network to get your feet wet. That's where you'll find the enthusiasm that the experts like Davis and other methodologists have with working with the clinicians. And that's where you'll find the excitement of sitting down around that table to talk about your shared interest of, in the example of Titus Media. Everybody's there for a slightly different reason. As you get more comfortable with sitting at the table and get more experience with the value others place in what you bring to the discussion, you will find yourself developing that momentum and more shaping your own research interests and perhaps the research interests of the group as you're better able to articulate your view of the question through your passion and your lens.
Yeah, and so someone doing that needs a mentor of their own if they're going to mentor others.
Well, it's like it's like therapists. You know, it's actually a requirement of psychotherapists to have their own psychotherapist. So you will not find an experienced mentor who cannot list a handful of mentors that they continue to still work with that help them in their work.
Yeah, excellent. Well, we're at the end of our time, and I do apologize for getting the late start today. I'm going to try to share my screen and see if it will work and take me down to our next, everybody see that? Our next development webinar, which is scheduled for July 26th, and we'll be focusing on qualitative research, in particular the use of focus groups. And so we look forward to all of you participating in that. We also have other events coming up over the next year. We'll be restarting Rural Prep Grand Rounds at this same time, and we're looking for teams of individuals to participate. So please stay tuned to those announcements. And then we'll have another professional development webinar in December. For those of you who participated today, we really are interested in your feedback and encourage you to click on the link that's in your chat window. Please evaluate today's webinar and give us feedback we can use in making these better. I want to thank Dr. Phillips for an excellent presentation. This presentation will be available on our website for download and use in other settings. And I encourage you to make use of these. In addition, I'm sure that Dr. Patterson, Dr. Phillips, and I would all welcome your questions or concerns. We can get you to the answers that you need. So thank you very much. I think that ends today's session, and here is our contact information, which will again be available on our website. Thank you very much.
Thank you very much.
Thank you.